evening and welcome to the Adult Health and Services Overview Scrutiny meeting. That's a good start. One sentence and I'd just about struggled through it. Hey? On Thursday the 30th July 2026, it's now 7 o'clock and I'd like to start this meeting. I'd like to draw your attention to the evacuation procedures that can be found in the agenda under the information for members of the public and councillor section. I would also like to remind you that under the overview and scrutiny procedures rules are part 1, paragraph 10, as set out in the Constitution. This meeting shall have a maximum duration of 2.5 hours. Therefore, if at 9:30, if there are items remaining, obviously they've done a very good job on the scrutiny. The agenda under the consideration will be concluded within 10 minutes, followed by a vote, and items not yet considered may be deferred for a future meeting. I would also like to remind everyone present that this meeting is being live streamed and recorded for publication on the council's website. Okay. Item 1, I have received apologies from Councillors Prince, Bennett and Linda Benson. Are there any others?
No, Chair. Okay,
thank you. Item 2, the minutes. The minutes of the previous meeting on the 26th of February 2026 can be found on the pages 5 to 14 on the agenda report pack. Do members of the committee agree to note these minutes? Okay, thank you. Item 3, declarations of interest. Does anyone have any declarations of interest to make? Take that as a no. Okay. Item 4, we're going to start off with immunisation in Thurrock, pages 15 to 28 of the agenda. Can I ask Rabinda Baines and Harpul Ajula to present the report, please? Thank you. And welcome.
Thank you, Chair. And we're really delighted to bring this item to Adults and Health Overview and Scrutiny Committee, and that's for a number of reasons. Firstly, this is a really important public health topic. It's the second most effective public health intervention and second to clean water. So this is a really important public health area. And specifically, it's a really important one for us to look at in Thurrock, mainly because we have low immunisation rates and low vaccine uptake. So this is quite an important topic to discuss. And today, over the next few minutes, my colleague Harpal will be taking us through some of the presentation. And then colleagues from NHS England, Oliver Jackson, will be giving a presentation. And also Emily and Emma, who are here from our provider services. With a specific focus around children's school-age immunisation service as well. So we hope by the end of this session on immunisations that you've got a better understanding about the importance and the collaborative work going on and systems approach to try and really improve the rates in Thurrock, and the opportunity to ask some questions for us as well to deepen your understanding. So I've just very briefly here is what the contents of the, so you've been, a paper has been shared with you all. The slide will be a summary of that paper, and it will cover the importance of vaccinations, the national and local systems involved in delivery, and as we've talked a bit about the data, some challenges in Thurrock, and basically give you an overview of the initiatives going on. So without kind of further delay, I'll hand over to my colleague Harpal, who will take you through the rest of the slide pack.
Okay, thank you, Ruby. As Ruby mentioned, so the World Health Organization say behind clean water, immunizations are the most effective public health intervention, and that's why immunizations matter so much. Recently, UKSA, so UK Health Security Agency, suggested that the flu vaccination program prevented 100,000 hospitalizations in just 24 to 25 flu season. So it just shows you the impact immunizations can have, not only on protecting us from disease, but our communities, but also the NHS as well, and relieving some of that burden on the NHS. Next slide, please. This slide kind of gives you a nice overview of the different partners involved in immunizations. As Ruby's been through, we have lots of different partners here today. So we have the Department of Health and Social Care, who set the national policy and priorities. We have the JCVI, so that stands for Joint Committee on Vaccination and Immunisation. They are the experts in the country, so they lead us on what immunisation programs we should have. So most recently, there was an outbreak in meningitis B in Kent, and it was advised that a different age cohort should receive that vaccination, so people going to university will receive that vaccination. So they are the experts that lead us on that. We have UKHSA, or UKHSA, UK Health Security Agency, formerly known as Public Health England, who give us that data, that surveillance, where there is emerging outbreaks. They will support us on that and give us that guidance on how to deal with outbreaks. We have colleagues from NHS England who commission the vaccination programs, and Essex ICB who help coordinate the delivery on that, so including our providers as well, help deliver those vaccinations. And then Thurrock Public Health, so myself and Ruby here representing today, we provide insurance, intelligence, and that community engagement, so really kind of that collaboration approach and really supporting increasing uptake in vaccinations. So this, how residents can access vaccination. So this is really kind of outlays the different ways that people can access vaccinations through different age cohorts. So for our children and young people, there are different ways that vaccinations are accessed. So through our GP practices, school immunisation service. So schools are a really captive audience, and we receive high uptake through that. And community clinics as well, so such as routine immunisations, school-age MMR catch-up, so that there's lots of different ways that children can receive the vaccinations. For vaccination during pregnancy, this can be attained from GP practices, community pharmacies, and community services. So some of these vaccinations during pregnancy is RSV, pertussis, and flu. And we also have our adult vaccinations, which again, the offer is through general practice and community pharmacies. So for example, flu, RSV, pneumococcal shingles, and COVID vaccinations are received for that. So the kind of message from this slide is that there's a variation, lots of different ways that people can access vaccinations. Just a little bit of data to show how Thurrock compared to East of England on this slide. So this is 24-25 data, so just bearing in mind that is last year. Compared to East of England, Thurrock appears significantly worse in uptake of vaccination. So you can see the column on the left is a routine childhood immunisation, so 6-in-1 it's sometimes known as, where it's red, so it's significantly worse than the East of England. We also have the MMR. So the MMR vaccination, that's one dose, is 84%. And to achieve something called herd immunity, we need to achieve 95%. So herd immunity is where if we vaccinate 95% of that cohort, the disease doesn't circulate in the same way. So those 5% that aren't vaccinated are also get that benefit of that herd immunity. And again, the next one is another uptake of that 6-in-1. If you do compare that to some of the feedback we had around different comparators, if you do compare that to some of the other, perhaps more statistically neighbouring areas such as Havering and Barking and Dagenham, we do compare a bit closer to them. So we, for example, if you compare MMR dose 1, so there's 2 doses of MMR. The first dose, even if you receive 1 vaccination of MMR, it is high level of protection. We're 85.7%. Havering is 85.4%, so we're slightly higher than Havering, and Barking and Dagenham are 79.5%. the data that we presented there is east of England. And it's a similar picture for our adults. So this is flu vaccination, so for 65 and overs. Again, we do compare significantly worse compared to our east of England average. Again, if you do compare that to Havering and Barking and Dagenham, we do perform slightly lower than Havering and above Barking and Dagenham. And also, if you compare our flu at-risk individuals, we are actually a little bit worse than Havering and Barking and Dagenham. So, again, flu at-risk is one of those cohorts that we really need to increase uptake on. Okay. And challenges affecting vaccination in Thurrock. So one of the big challenges is that population churn. So the nature of our demographics, we have quite high migration in demographics and our population structure. So our population, we have a younger population in Thurrock, so you have to bearing that in mind, it can be quite difficult to access vaccinations. We also have differences and coordination in changing system as well. Another area that we really have a challenge in is misinformation and disinformation. So one of those, one of the key drivers for that is social media as well. So that the way that misinformation spreads quite quickly. So that can also be another barrier as well. And what that means is there is a potential impact of higher risk of outbreaks. As I mentioned earlier, when I gave that flu stat, it does increase the burden on other services such as the NHS. So carrying on to those risks on to Thurrock residents. So this challenge isn't just locally to Thurrock; it is a national challenge. For example, if we look at MMR, measles, mumps, rubella vaccination, there has, since COVID, has been a national decline. We've seen nationally over a 2% decline in that vaccination. So increasing that vaccination is a national issue, and there are some key areas that we can really improve in. And I guess the kind of key message from this slide is that we need to really understand what those risks are and what it can lead to if we don't start making an organised effort to increase that uptake. Some of the opportunities to improve, actually, can I skip this slide because Oliver's going to cover that in a bit more detail than me. So some of the NHS vaccination innovation supporting Thurrock residents. So we do have some really good evidence base around how we can increase vaccination. So call recall services, how GP services and other services can call people for their immunizations and how the different methods we can do that in. So whether it's text messages, phone calls, email, different things. So there's different ways, and there's strong evidence base on if it's, for example, a direct GP booking, how that can increase uptake. So we also have our maternity vaccination pathway, which can be a bit more personalized and easy to access. So depending on appointments, that can be a lot more easier for pregnant women to access that vaccination. For example, flu. If flu vaccination is often offered when they are with a midwife, that can really increase uptakes. And so there's different innovations through that as well. And also offering patients vaccinations when they're in the hospital setting. So there's lots of evidence base around different things we can do to increase vaccinations. And all that leads to that kind of things I mentioned before around reducing the risk of outbreaks and reducing those health inequalities. Okay, and that leads us to the two kind of recommendations that we really want to make here today. So one is really acknowledging that risk to our population, especially some of those vaccinations that are particularly low. It does leave us risk to outbreaks, and one of the kind of things that we've been looking into is the kind of cost of outbreaks as well. So there was an outbreak. It's based on an outbreak that was about over 10 years ago, but it does say that, that the cost of an outbreak costs 20 times more than the actual vaccination. So it can be actually a big saving, not just on from a money point of view, but also from a return on investment point of view as well. So that calculation was done not only on the cost it takes for people to take time off work to care for children, but also the cost to the NHS, the cost to people doing contact tracing. So it involves a lot of different things like that. The second recommendation we want to make is supporting that collaborative approach and the actions being taken to increase uptake of vaccinations in the Thurrock population.
Thank you. Hi, I'm Oliver Jackson. I'm a Screening Immunisation Manager for NHS England's regional team in the east of England here. And NHS England's responsible for commissioning the Section 7A immunisation programmes. So if we go to the first slide here, this is a table that shows broadly the range of vaccinations in the first column throughout the life course, and across the columns show the different settings that one can get vaccinated in. Typically, vaccination has occurred, the core delivery service of vaccination has been through general practice, and with the teenage vaccination programs delivered through schools from the school age immunisation service. And I think what's key on this slide is that over time, we're seeing more delivery for vaccinations through community pharmacy and through community routes, through our community and school-aged immunisation service. So whilst we're trying to increase access to vaccination across a range of settings, which is illustrated by this slide. Next slide, please. So linking in with that theme, I thought it was useful to show the expanding role of vaccinations in community pharmacy. So around the turn of the millennium, we only had private vaccinations given in community pharmacies. And then I think it was about 2014, we had initial pilots for the seasonal flu vaccine as an NHS programme delivered. And then what I really want to highlight is from January 2021 onwards, there's been a huge, rapid rollout of vaccinations across community pharmacy, which is really good at increasing access to vaccines. So from 2021, we had the COVID-19 vaccine, and then more recently, we've had the Pathfinder programme for RSV and pertussis vaccines. We've also last year had the children's 2 and 3-year-old flu pilot as well. And then this year it expands further. We've just started the new meningitis B vaccination programme, which is being delivered solely through community pharmacies with community catch-up. And then further support and further increased rollout for the flu programme from October and December of this year. So huge additional points of access for the population. Next slide, please. So I've mentioned the school-age immunisation services, and typically they deliver the teenage vaccination programmes in schools. Where we're a bit different in the east of England, we've added the C to that, the community element, community and school-age immunisation services. And as part of our procurement process, we've added in a range of additional services. I won't take you through all of them, but you'll see a number of bulleted on the screen there. So examples will be that we've got a really robust outbreak response service. So if there's an outbreak of, say, measles or hepatitis A in a school or a nursery or a different community setting, we've got a team which are ready to respond to that really rapidly and try and prevent further community transmission. We've also got a Send Partnership Plus service, which is fantastic at increasing access or creating more tailored services for those with learning disabilities. And additionally, more outreach work. So outreach work for particular communities. We've provided a vaccination ban that can go to events, it can go to different sites, going to the hearts of community to provide vaccinations where the need is. And that's really, really key. And also, just to pick out here, it's a 7-day service. So a lot of these services are delivered throughout the week, weekends and evenings, just to make it easier for people that live busy lives. Next slide, please. So I just want to take you through some of our innovations. So these are the things that are being done very specifically in the east of England. So we just want to highlight the first one there is our immunisation call and recall system. So typically, parents of children will get reminders, they'll get letters, they'll get text messages, letting them know when their child's vaccination is due. Now we've developed this service so that we can identify children that are under-vaccinated, and we can have tailored conversations with the parents of those children to understand what the barriers are to vaccination, just have an open conversation and to try and help alleviate their concerns, and then ultimately try and signpost them to where their child could get vaccinated, which could be at their GP practice, or it could be in a community setting. It could even be at home as we commission a domiciliary service. Linked to that, we have the direct booking project. So where we've identified children that are under-vaccinated, we want, as part of that call to action in that communication with the parent, we want to make it easy for them to finish that call and decide, yes, if they wish to have their child vaccinated, we want them to end that call knowing where and when they can get that child vaccinated. So direct booking allows the call handlers to book the child in with an appointment in their GP practice rather than solely in a community clinic. So for a number of parents, that's just a little bit easier for them. It's a more trusted location. And we hope in time that could be done digitally in due course. The next item there is the development of the adult immunisation system. This is very much a work in progress that we're just rapidly trying to roll out. Similarly to the child health immunisation system, where invites go out to children, this is about sending invites to adults to let them know of their eligibility for vaccination, because we know that's one of the main barriers. People with busy lives don't necessarily know that they're eligible for a vaccine, so maybe a simple text message or a letter is all they need. So we did a pilot 2 or 3 years ago with the shingles vaccination, and we doubled vaccination uptake as a result of merely sending a letter to those eligible adults. So we're hoping to sort of roll this out regionally now that we've got the technical ability to do so. Next slide, please. And so these are a couple of linked items here. So maternity delivery. So we're really trying to increase vaccination uptake for pregnant women. And one of the best ways of doing that is taking the vaccine to them. So we've commissioned Basildon Hospital through our community and school age gym service to provide vaccination services in the maternity unit to really make it a one-stop shop, make it nice and straightforward and easy to access that vaccination. And complementing that service, we have an RSV vaccination program where all pregnant women will be contacted directly, informed of their eligibility for RSV vaccine, and they'll be booked into a community clinic of their choosing. And then the acute vaccination service, that is really an extension of the maternity service, where we want to increase access to vaccination for all inpatients and outpatients. So for those that are waiting for an appointment, a consultation or something, we want to make it easy for them to get vaccinated while they're there in the hospital, so that they don't have to go on to access the vaccine elsewhere. And I think that's the last slide. Thank you. So I'll hand over to my colleagues from HCT.
Thank you.
Right one. Thank you very much. Okay. Good evening, everybody. My name's Emma Whiteford. I'm the Director of Operations at Hertfordshire Community Trust, which covers adults and children's services. And really my role here is tonight to introduce my super colleague, Emily, who will talk in detail about the service she provides. But I also thought it's important to provide a golden thread through everything that my colleagues have said, not only the people that buy my services, but people who I have to provide an assurance and oversight to. So HCT covers a massive area for vaccination programmes. Bedford, Luton, Milton Keynes, you know, a large chunk of Essex as well, right into Hertfordshire. So we are a big player on the national stadium for vaccinations. Notwithstanding that, we absolutely recognise that Thurrock and its locality has a specific and a bespoke need. And we recognise the areas of deprivation. I won't steal Emily's thunder. She's going to talk more about how we're addressing those. It is a jigsaw puzzle. I could understand from a counsellor perspective, when you look at some of the slides, it looks like a patchwork quilt. And it is, and it can be complex to navigate, and we want to try and support that, that every opportunity a child or a family comes to HCT, whether it's in Thurrock or anywhere else, we take that opportunity to educate and take the opportunity sometimes from a consent perspective to vaccinate not only the child that we've been presented with, but it might be mum, dad and siblings. It's not uncommon when we interact with those people. Prime example, at the weekend, for 4 days, the team in the bus on the screen was at Latitude. We had 75,000 people there. And we vaccinated 700 of them, but it wasn't just MMR, that was mum, dads, kids, teenagers, the whole 9 yards. So it's a really diverse offer. We recognise the low vaccine uptake around Thurrock, and we just want to reinforce that opportunity about working with the local community to improve that. So I'll hand over to Emily. Thank you.
Hello, my name's Emily Chiesa and I'm the Clinical Quality Lead for the East of England Child Health and the Community and School Age Immunisation Service, and I'm very pleased to be here today to be able to showcase our service to you. So we have a business as usual model which we run across the East of England and have been doing for a number of years. We go into every school in Thurrock and across the East of England and vaccinate in Year 8 and Year 9. So we offer the human papillomavirus vaccine, meningitis, ACWY, and the diphtheria, tetanus, polio booster. We go offer schools 2 visits every year to make sure we capture as many children whose parents consent for vaccination on those days that we go in. Essex was actually one of the first teams in the country to use the new NHS Digital Managed Vaccination in Schools e-consent system, which we have supported the development of. So it looks very much how we want it to look. And it is proving to make a real difference with us understanding whether parents want to consent or decline vaccination. It's so easy for them. They get an SMS to their phone and they press yes or no. And that really helps us to get the feelings and the wishes of the parents. We can understand that really easily from that. But we don't only go into schools. That is one now small part of our job. We also offer multiple community clinic offers to young people who we don't manage to vaccinate in school for whatever reason, but also those who are electively homeschooled or are not in school for whatever reason. So it's school-age children that we vaccinate. Being in school is the easiest way for us to capture the population, but it certainly isn't the only way. And as Oliver has said, we offer community and maternity unit-based clinics for antenatal vaccines, and we also are the provider that provides BCG, the tuberculosis vaccine, and the hepatitis B vaccine to babies that are born to mothers living with hepatitis. So Thurrock specific. You have a fantastic team in the Community and School Age Immunisation Service in Thurrock, and they are dedicated to improving uptake in Thurrock in the populations that we serve. Every family who doesn't respond to the initial contact for from our service will have up to about 6 contacts from us via SMS or telephone call, so that we can really record and understand the parents if they want to consent to vaccination for their children, and to offer them community clinics. Just to illustrate this year there has been 79 community clinics, and there's another 20 booked between now and September. And I've been in the office today, and they've just got agreement to be able to work at Thameside House on a Saturday, so there's going to be even more clinics offered in Thurrock. We have walk-ins and booked appointments. We've attended big lunch events, health and wellbeing events. We do home visits for those that can't get into clinics. So, for instance, people with large families. Just today, the team were out at a family there were 6 very young children in that house. We've been out to them and vaccinated those children, and we'll continue going until we've got them up to date with the schedule. We do a lot of partnership working. We do a lot of parent evening offers in secondary schools, so that we go in, stand there, talk to parents in sort of year 7 intakes and things like that, so that we are visible and parents can come and talk to us about any concerns. More recently, the team have run a primary school MMR project, and they've managed to vaccinate a lot of children in primary schools that were missing MMR vaccines across Thurrock. And just to illustrate, they've also replicated this in year 8, 9 and 10, and they've given 430 MMRs since the 1st of June this year in that school project. So there's a lot of work being done to improve measles, mumps, rubella. SEND schools have multiple visits throughout the year because those children are in and out. You never know whether you're going to get them on that day or not, but they go in and out and catch up those children. And we've talked about the maternity vaccines provided at Basildon Hospital. Next slide. So our future plans. So we are looking to build a specialist team to focus on access and inequalities for all. Now, that will be across Essex, but Thurrock is most definitely our focus. So that team will work across Thurrock as a priority. We are looking to address why we get so many declines for vaccination, and we'll do that through education and engagement. Just quickly, we chase non-responders to consent SMS before sessions in school, so that we will continue to do that. Mavis really helps us to be able to identify those families and that haven't responded to us, and we give them a call and ask them whether they'll be happy for their young person to be vaccinated on the day. We need to work with the Harris schools in order for the issues that we have there. It's a complicated, and if anyone wants any more information on this, but they are unhappy to provide parental contact details with us, and that stops us being able to use the Mavis e-consent system as effectively as we do across the rest of the east of England. And it's been, I think it's about 75% of the country are using this system now. So it's something we feel we can get over, but and we're looking, as I said, to run our clinics from Thameside House at the weekend, and just today we got that confirmed. So there's a lot going on. We do a lot. We are kind of a thread through vaccination from cradle to grave, and we're proud of what we do. We have a very specialist team that deliver these services, and so we're hoping to make a real difference.
Thank you all. I hope you've had the opportunity to obviously hear and digest. I appreciate there's a lot of information around immunisations. It is a complex area. There's a number of them, and it's not just one place you can get all your immunisations. There are, various touch points. But I hope today you've had an opportunity to kind of hear from different perspectives around the topic, and also the amount of work and energy and going into this. I should note also a thanks to other colleagues in my team who are doing a lot of the hard work that aren't here today, and liaise very heavily with Oliver and Emily and Emma's team, Galina, Gukam and Beth Capps, who are support Harpal in health protection, and they do a lot of work to make sure we're working together well as a system. But happy to take questions.
Councillor Snick.
Thank you, Chair. Just one question. Where they do better in other parts of the country, do you reach out to them for information on how they, achieve better results? That's something which would be good for Thurrock, because, as a resident of Thurrock, you obviously want to see the best for the people of Thurrock, Also, just another question. I don't know where Thameside House is, so as if I don't know, a lot of other people wouldn't know,
So thank you, Councillor Shinnick. Really good questions. And I think we were just having this discussion earlier. So I'm going to kind of hand over to Emily and Emma, because they actually provide that element of the service across Essex and a greater footprint. And you've seen the East of England region. There's other places where you're delivering the service, and Oliver, with your regional perspective as well. So, and we're always keen to listen and learn, and implement anything we need to do. And obviously, we do have those other conversations where we're seeking to get more energy going into Thurrock, because we've got a greater gap to reduce here. But yeah, hand over to Emily and Emma first, and then maybe Oliver to give a different perspective.
Thank you. I've learnt my button question now. So we actually provide the same service that is the top of the league table up in Cambridgeshire. So absolutely, we take the learning from there, but recognise the offer and the population is completely different than we have up in Cambridge. So we take the positives and the learning from there. The bus that we have at Latitude and driving round was great for the rural areas. That's where it started. But actually, it means we can go to the hard-to-reach places as well. So we can use resources like that in a really effective way. And I don't know where Thameside House is, but I'm going to ask Emily if she does.
I understand Thameside House is somewhere in the hospital, but when we send out postcode directions, there's nothing to worry about. We would let people know, and we're everywhere. And just today, they were thinking about seeing whether they could get the bus in Lakeside Shopping Centre car park. So there's stuff going on all the time. I've got a list of kind of venues that we go to. So Grays Health Centre, Tilbury Health Centre, Purfleet, Chadwell. So they try to spread across to make it as accessible and easy as possible. But just to echo what Emma said, we are across the east of England. Be honest with you, somewhere like Norfolk, we can get 85–90% just by opening the doors uptake. And in other areas like Luton, Peterborough and Thurrock, it's much, much harder to get the 75% that we've so far got this year for our DTP Min ACWY programme in Year 10. It's a really hard slog. I would say education, public engagement is so important, and we're looking to do a lot more co-production work. We have a video at the moment, you can see on our website, that we co-produced with young people across the east of England to try to educate them on the vaccines that they would be offered in school and what a session would look like in school, because that's what they wanted to know. And we're looking to do more work like that with other groups as well. So yeah, there's a lot going on. We're giving them the convenience. We're trying to promote the confidence, but we need to alleviate the complacency. So the 3 C's of vaccine hesitancy.
Councillor McCabe, you've got a question.
My concern, and it's quite a big concern I have, is that I know of at least 3 babies that have been let out of hospital without having the appropriate strep C injection given by the midwife to stop deformities happening. As soon as the baby leaves, there's trouble, the oxygen stops flowing around the body and things start to go dreadfully wrong. And they had to dash them back to hospital in order to put it right. And I don't know how you can relay how important that injection is. And it's given by the midwife before the mother leaves the hospital. Do you see what I mean? So if there was any assurance that anyone could give me that happens as a par for the course.
Just to note, there isn't a national vaccination programme for strep C. That's not something I can specifically comment on, unfortunately. When we've spoken about our maternity vaccination services, we're talking about the RSV vaccination, respiratory syncytial virus, pertussis vaccination or whooping cough, and the seasonal flu vaccine. So those are the three that we work really hard on to try and increase uptake.
Councillor Stringer, thank you.
Two questions really. One, I may have already got the answer for it. I've seen that the flu vaccinations are quite low, the uptake's quite low here. I didn't realise you actually gave them to young children as well. I just wondered, because you'd mentioned that Thurrock had got a younger people moving around of a younger age, I thought maybe the uptake was because the low uptake was because we've got more young people, not the older people, but I understand you give it to the young people as well, so that might have answered that. And the other thing, obviously, is the low uptake. Is it a cultural issue that we have with the low uptake?
I'll just give a broad brush, and then I'm going to hand over to colleagues, because I think it's such a big question that we're trying to work out nationally as well as locally. It's more pertinent for us here in Thurrock, obviously, because we've got lower rates. But overall, the backdrop nationally is a decline. It's recognised that we need to do better as a country for immunisations, and we need to get the messaging right. But there are a number of factors that could go into why uptake is low. People's views, they have concerns. There might not be anyone to talk to about those concerns, and that's really important. People have an opportunity. There might be access issues in terms of coordinating and getting to your local GP, or even knowing about all the amazing work that is going on. And there might be religious reasons why people think, actually, I'm not sure if I can have that vaccine, or cultural barriers to it and cultural beliefs as well. So there's a wide, and I would say also Thurrock, relative to certainly the rest of Essex, is we've got a higher proportion of ethnic communities, and actually some of that might be playing a bit of a part. But also, I think, given that, it's important to recognise that there's lots of other factors, so I don't think we could tease out one point, but I will go to my colleagues who are working on this day and night, obviously.
Yeah, I'll just, I suppose, support Ruby's point as well. It's not a single reason that we look at. Accessibility is really important, but that could be language barriers. It fundamentally, for me, sits with education. So if people understand the rationale behind having the vaccine in their own language, whether it be written, on a text message, social media, that's really important. Actively listening to their concerns about why they don't want the vaccine, allowing them time and space. It's not unusual for us to have a conversation, they go and have a think about it, read some material, and then come back, and then they're quite happy. Sometimes you can vaccinate children who have been super keen to have the jab. They've actually educated their parents, grandparents and stuff at home. So it's not a single element to it. As Ruby said, an element can be culture, but I wouldn't say that it's the only reason. We can have very well-educated people on paper who have some strong views about not having it. So it is complex, and we try and offer a suite of options to address those concerns.
Councillor Stringer.
Yeah, can I just follow up on that? I'm one of those people that don't like vaccinations. I'm 73, and apart from COVID, I've never had a vaccination in my life, because a child down our road had a polio vaccination when I was about 2 years old, and it gave him polio, so my mum wouldn't have any of us done. And it was only COVID that I've got a grandson who's got an immune problem, so I really got frightened into COVID. Otherwise, I wouldn't have had the injections. I'd done it for fear of my grandson. Do you feel that the whole debacle over COVID has again caused a decline in vaccinations? Because a lot of people I know sort of felt that it was all a conspiracy, you know, and I honestly think that's cut a lot of the uptake of vaccinations down.
Like I say, I mean, our role is a health promotion element to it. I wouldn't want to disappear down a hole of, you know, you're absolutely, you know, entitled to your opinion that, you know, we are not here to change people's views. We are here to respect them as long as we provide all the information that we possibly can, and people, you know, can have the ability to make that decision. From a COVID perspective, I don't know about my public health colleagues, but the conversation about vaccination, whether it's COVID, flu, MMR, is definitely in the wider forum for people to discuss. So that might be one small positive of COVID, not that I want to go back there at all, but there is, you know, it's in the domain. The fact that we're talking about it here tonight maybe demonstrate that it's more in the language at the minute. Thank you.
Councillor Ellis?
Yeah, on the point of sort of when you're calling the parents to see why they're not taking the jabs, do you sort of take out the research of why they're not doing it, so you can sort of target, in a public health sort of way, target why they're not taking them, if that makes sense?
So we run the call and recall service that Oliver alluded to. And yes, we do talk to parents and understand why they are declining vaccination. And it can be for a whole host of reasons. And often it is simply through not understanding that their child can actually have the vaccine. So they might have got medical conditions, they might have allergies, there's a whole host of reasons. The actual numbers of families that do not want their children vaccinated is actually very, very small. But there is education issues, and that's what we do. And we have used something, trained all of our senior nurses and administrators actually recently, something called Jitsu Vax, which is a way of being able to talk to people about vaccine hesitancy. It's something that was put together by the University of Bristol, and it has really helped us have those conversations. And it's just about hearing the concerns, about normalising them, because if one person has got them, so has somebody else. But often there are ways that we can help to debunk some of the fears and myths around vaccination. And we do that in a very open way. And if a parent at the end of that still wants to decline vaccination, then we are more than happy to accept that decision. And not only that, we're happy because we've had the conversation. It's their decision, and we can document that clearly on the child's notes. That's much better than non-engagement. We love engagement.
And just to add to that, I was just going to reflect on our call and recall service, and yes, that's one of the key aims of it, is to collect the barriers to vaccination, what the parents or reasons are for not getting their child vaccinated. And obviously, as part of that conversation, the call handlers try and have an open, power balanced conversation with the parents to try and understand what their concerns and their issues are. And obviously, we'd like to sort of try and overcome those issues, and we'd like that to lead to vaccination at the end of the conversation where possible. But then what we would like to do is try and take some of that data, some of the information that we're getting, and use that to try and prevent barriers for future children. That's what's really key, so we can try and understand, is it an access problem? Is there an issue with the GP practice maybe that doesn't have a particularly accessible appointment system, or is there a concern going around a particular community at the moment? We can then get that data and work with those communities or those providers to try and overcome those issues.
Actually, I have a question. I guess it's either Rob, Emma, or Emily, as you seem to be our favourites at the moment. Just a quickie. The first one is delivery routes. Now, we've obviously been referring to the NHS coming from I mean, I've worked in the city and in London for many years. A lot of organisations have their own private sector vaccination programs. To what extent, okay, is your data maybe slightly skewed because those other programs have taken precedence, maybe on the flu jabs, for example, which, so I don't know who to frame that to.
So thank you, Councillor Irvin, for that question. I think there is a lot around vaccinations, and obviously the ones that we work with our partners on are the ones that are the nationally recognised ones for those particular cohorts who are considered at risk and where there's been an evaluation of risk and benefit. And these decisions and policies, going back to one of our earlier slides, they're not locally derived. They're high-level committees, national work that kind of guides us on that. I think there are lots of opportunities for people to independently go and get some vaccinations privately, but I certainly think that, you know, my understanding, and I'll kind of come over to Oliver, is, you know, what we are interested in looking at is those vaccinations that are nationally required. The system that we have in England, you know, it's a robust immunisation system that's recognised. So we've got, so, and you know, there's kind of thinking about the Green Book. There's an entire book around who gets vaccinations and who doesn't. So there's a lot of energy that goes into working out, you know, risk and benefit, and who's it going to benefit. But I don't know in terms of the data. I think we look at the cohorts that we need to, but
Yeah, I think the vast majority of vaccinations are delivered through NHS services. I think where there is a gap is with occupational health services, particularly. You mentioned the seasonal flu vaccine, and that's a key one where a private organisation might offer the vaccine to their staff free of charge, often via a community pharmacy or something. And some of that data is often lost. It doesn't feed into NHS systems. So there is a gap there. A number of those people will be healthy individuals, so may not be eligible for it under the NHS service anyway. But we need to recognise there will be a number which would have been eligible because they were perhaps in a clinical at-risk group. And that, so certainly for flu, there will be an element of underreporting on the data.
Thank you for clarifying that. Councillor Hill.
I just wanted to ask about, have you thought about going out to, because every ward has like a community hub that a lot of people do attend weekly, and it's quite a big thing, and it's something that we could support you guys, put it on our Facebook pages, NHS, because I met the mobile team up at Hassengate opening. There was a fun day there, and I spoke to the mobile team, and I thought it was fantastic, and we could support you as much, and I think this might be another little outlet for you guys to maybe investigate.
We are always looking for opportunities like that, so yes, please.
I'd just come and add a point, and this is absolutely one of the reasons why we brought it here, actually, is because we would welcome your engagement. And I think where we have got outreach into the community, if we, you know, like I said, a couple of colleagues who are working on this quite intensively, we can do that, join up, and I think that would be fantastic.
Kim?
Thank you, Chair. I don't have a question, but I have some feedback, just for a change. We have been working with Galena, is it? Fantastic. We've actually got somebody we can drag around Thurrock and point her in the right direction. So we're at the moment doing some work with the traveller and showman communities with her to get her introduced into there, and I think that the bus there would be a big hit. And if you play their rules, they'll let you in. Please don't talk to them about not smoking though, because they'll throw you straight out, as was found in the past. I don't know why, but they don't like that conversation. Plus also the bus, we absolutely loved it. So we pitched in with them because obviously we were out there engaging with people. So we set all of our games and all of our activities at the big lunches, at the wellbeing days, so that we enticed all the children to us, so that the mums could then have a conversation about, and a few of them were picked up at the events, which was really, really good. We have young Health Watch ambassadors, and they go from 10 to 21. And a lot of the work that they do out in the community is talking to their peers about all sorts of things that affect children and young people. And 2 of our young people actually had their meningitis B jab because they'd just reached that age. So we got them in there so that they could give some feedback, do a little bit of a video about what it was like to have it done. Plus also what we've asked them to do, which people, I don't think they realise, young people when they go to university, if they're going to go into any health courses, so we've had a couple that have gone in to be paramedics that have done their placements with us before they've gone from college, and a couple that have gone into nursing. If they haven't had all of their vaccinations and they're not up to date, they actually won't let them stay on the courses, especially when it comes to them going out and doing the practical stuff. And there were a couple that hadn't had them, not for any reason other than their parents chose not to. There was no medical reason not to. And they were actually put on the spot of, you either have it done or you can't do this course. So they've done a big piece of work as well, where they're advising young people to make sure you go and get it done. They do get it done at the university, so they do, but they drag them and make them do it. So it's just really good information that young people are sharing with young people.
Thank you. One last final question. We're enjoying this. Councillor Ennick.
Sorry, just a more technical one, let's say. So I'm reading now that in 2025, 2026, the influenza vaccine effectiveness in the UK was somewhere between 70 and 75% for children, and 30 to 40% effective for adults. The aim, as you said, was to get to the herd immunity. I mean, vaccinating 95% of the population. So even if you vaccinate 100% of the population, if the effectiveness is 30 to 40%, or in the other case, 70 to 75%, how will you be able to get to herd immunity in that way, you know? So does it make sense?
Yeah, that makes sense. So for the flu vaccination, the vaccine changes year on year. So we look at what's happening in the southern hemisphere, so Australia, what flu strains are circulating, and that influences, it's a prediction model, influences what flu strains are going to be in our flu vaccination. So year on year, the vaccine effectiveness changes. So especially in the children's program is seen, Oliver, you can correct me if I'm wrong, the children's vaccination program is seen as the one that can really stop the circulation of flu strain. So that there was research done when the flu vaccine came out for children that herd immunity was actually a lot lower than that 95%. I think it was when the flu vaccination for 2 to 3-year-olds was introduced, it was around 50-60%. But most vaccines, for example, the MMR and other vaccines, you do have that higher 95% for herd immunity that you need. So I hope that kind of answers the question, but it varies from vaccine to vaccine.
So basically, that 80-something% that Thurrock actually has at this particular moment is not so bad.
That's the adults, the 65 and over. Sorry, was that 65 and over vaccination? Sorry,
yes,
for flu. Yeah, so we do still want to increase that uptake because it just stops that circulation. Yeah, the statistic I gave around how much you can save on the NHS, if we're able to increase that uptake, is probably that key thing that we really need to work towards, and increasing that vaccination uptake. But it does vary. For flu vaccination, the effectiveness does vary year to year, so we don't quite know until after the flu season goes how effective that vaccine was.
Councillor Irving.
Okay, sorry.
Sorry, we'll just add one last kind of final thought before we kind of close the conversation. I think it's worth remembering in our minds that there was a time when children died from some of these diseases, and we're in a place where we're, many kind of decades on that we're not in that situation, but we do still want to collectively continue to work. So it is making a huge impact on not only in terms of finances, but in terms of health and mortality as well, and especially, all the work that goes on with flu is to keep our residents out of hospitals as well and keep them well at home. So it's a kind of human cost to all of this as well, which really we need to remind ourselves about.
All right, so thank you very much for that. That was really insightful. So really following on from that in terms of the recommendations, a couple of things. For the reasons set out in the report, the committee is recommended to acknowledge the risks that we've obviously got from the population in terms of communicable diseases due to the low rates that we've got. Now, with that in mind, obviously the support that we want, obviously with a collaborative approach, perhaps we can liaise with you, maybe set up a set group to liaise with you and find where within our wards we can provide you with additional assets and possibly maybe at the same time that we do some of our surgeries, for example, could be an opportunity for you to do them, for example. So we will certainly be liaising with you as fast as possible and not taking any time on that one at all. So yeah, so it's basically that. So thank you very much, and that was very good. So thank you. Okay, item 5. We're moving now on to the Mid and South Essex Foundation Trust. This is the One Team Improvement Plan, and this is on pages 12 to 36 on the agenda. Can I ask Maimouna Mishabi, have I pronounced that correctly? Okay, thank you, to present the report. Okay, thank you.
Hi, good evening. I'm Maimouna Mishabi. I'm a pediatrician, and this evening I'm representing Mid and South Essex Hospital. So I'm the interim CEO for Basildon Hospital site. I'm going to give an overview, and then people can ask questions. So as people may be aware, the trust has been under a lot of scrutiny from NHS oversight frameworks and recovery programs. And we've been working closely with NHS England. And in March, we are one of the 5 organizations in the country that were put on the intensive recovery program. We came late to it, so we started in June, and we are finalizing what those projects are going to look like. That will be making improvements in the organization, and this will run until March. And some of the programs that we are looking at, so we've recently reorganized the leadership of the trust to have clear oversight for the hospital sites and how they deliver services within the locality. So for Basildon, particularly how we work with Basildon population and Thurrock. The second element is we are in the process of implementing an electronic patient record program, so called NOVA. We've finished the building of the system. We are now testing, and then hopefully in March we'll start training for our teams, and we should be up and running in July next year. And it's really, this will, I think, change the way we work, because we'll have oversight all the way from the hospitals across the community so that we can share patient records and do things in real time. The other element, of course, we are looking at in terms of our waiting times. We all know that they are very long, and we are working through the processes of how we improve things in real time. And the aim of this program really is to improve things, but also lead to sustainability, because I think we've been through different improvement programs, so we really need to get into a steady state. And some of the progress we've made, so for example, around our ED waiting time and corridor care. So Southend really has eliminated corridor care. Broomfield and Basildon are also on track, and we are working using this program to really eliminate corridor care, because we realize, and our ambition is to make sure that none of our patients in our population should be receiving care in the corridors. Last month we received feedback and compliments about 700 from our patients through our patient experience team, which is an increase from the month before. So in terms of things that are happening in Thurrock, so we have the CVS by your side, which is a service that works alongside the hospital teams to make sure that patients are discharged in real time to prevent delays, but also causes a saving by reducing the length of stay in hospital, so about 1.8 million, then that money can go back in the services. We have the Thurrock Community Diagnostic Center, which was opened last year in September, and until around May this year, we've delivered nearly 30,000 investigations, which include CTs, MRIs. We are expanding the services that we deliver, so we've opened a children's audiology center, which tests their hearing. They'll be starting a coagulation service within the center, and we are looking at what other services we could deliver within the diagnostic centers, and that's real to try and bring the services closer to the people and prevent them going into the acute hospitals. So we have an anchor program which works with our population, and there will be a case study for people who have managed to read the paper, but it's how we work with some of our young people who may be in the community, maybe with learning needs or who are neurodiverse. How do we help them get into meaningful employment? We have a youth work system in the hospital. So this started just before the pandemic, and it was rolled out by the Essex Police. But we have youth workers in the hospital who work within our EDs, work within our children's clinics, particularly with young people who either have mental health or have chronic illnesses. And there's lots of case studies that have now shown if you manage to get to the young people at the point of crisis and work with them, you prevent them from going into prison. They stay longer in education, and they have a meaningful life after that. So we're really proud of that service, and it's an award-winning service. So I'll stop there if people have any questions.
Any questions with regard to that, with the improvement point? Councillor Stringer?
Not got a question, but the Thurrock Diagnostic Centre, I actually went there Sunday night for an MRI scan. Absolutely beautiful place. It's really didn't feel like a hospital. It was really lovely. It's great there.
Thank you for that feedback.
So can you, can you just tell me a little bit more about this new patient improvement system that you've just referred to?
Is that an electronic patient record system or Nova? Yes, yeah. So, for people who use the hospital, we have a mix of electronic, so digital and paper. And that is a real problem even within the hospital. So to give an example, you could come through our ED and see a doctor, and then you're admitted on the ward, and someone has to wait for the paper notes to come. And if they get lost along the way, then that's a problem. The ambition really is that we should have a digital system, not just within the hospital, but also across our community services. So we worked in collaboration with ePut to buy this electronic system, which is already being used in some other hospitals. And we've built the systems in a way that we can do the prescriptions. If I made a prescription today, then if my patient ended up for example, in community, they could see the discussions we had, they could see the medication I've prescribed in real time. If I saw a patient in clinic, for example, and I did a letter, it doesn't have to wait for 10, 20 days when someone is typing it. It can be in real time communication to the GP. And I genuinely think it will be a real change in the way we deliver services, and we'll see benefits from that. And some of the challenges, for example, at times we have patients who need to go home, but you're waiting for the resident doctor to go and do the discharge later, write the medications to the GP. But these will be real-time systems that capture information so that you can then get patients out of the hospital. I think the challenge is we have a huge number of teams that we need to train and get ready, because people by behaviors. If they're used to one thing, changing them can be difficult. And so we are organizing ourselves in a way that we make sure they're trained and the hospital doesn't come to a halt when we implement. But yeah, we're excited about the system.
Just a little follow-up to that. So with that, is it very much a local system, is it? Or is it going to be a little bit more widespread in that, for example, if I've got a child with complex needs, yeah. Sometimes they need to see a specialist outside of area or Essex County or Ipswich, or have to go into London to a specialist centre to cardiac and rheumatoid arthritis, etc., whatever it may well be. Is the aim to migrate all patient records onto this system, or is it ultimately?
So Essex, we made a decision to go with this system, which, so for example, if you look at London hospitals, so for example, Great Ormond Street Hospital, Evelina Children's Hospital, Addenbrooke's, they've bought the same system and they can communicate. The system we've gone with would essentially cover Essex community, but it wouldn't communicate outside the borders. I think the ambition for the NHS eventually is that we have systems. You can see a patient on a need basis. So if if I sent you child either to Addenbrooke's or Evelina, they could be able to see information, but it's not, we are not yet in that space. The initial space is really to make sure that Essex as a system is communicating with the acute and the community. So that's where it is at the moment.
Councillor Shinnick.
Yeah, thank you for your presentation. Regarding the diagnostic centre at Thurrock Hospital, I've come across quite a few people that have tried to book online blood tests there and unable to. Apparently they have to ring a number which they can't get through on half the time. So it would be worth looking into if we could get that up and running online, that patients could book, the blood tests there. And I had the privilege of opening that centre with the health minister when I was mayor, and it's all singing and dancing, and I don't think we're utilising it enough at the moment. And we spent all that money on it, and I'd love to see it up and running, more, and it's all cities getting run down. One of the nurses I know there, and she said it's appalling, it's falling apart. So we need to utilise these diagnostic centres to the potential what they have, because it's unbelievable what you can do in them. Thank you.
Thank you, Councillor, for your reflections. I think I agree with you 100%. We need to arrive in a position where we provide services more in the community. So we know that NHS Ambition 10-year plan is to really move services more closer to home. And so we've been reviewing all our community diagnostics. So we have one in Thurrock, we have one in Southend, there's one in Braintree, in how we enhance the services we deliver. So we've been looking at around the online system for blood booking, so Swift queue, so that people can go in and look and get slots. So I'll take that back to see where it is. But yeah, that's the ambition, because you try calling the number, if no one is responding, or it's a weekend, then it's a problem, isn't it? But yeah, thank you for that feedback. I'll take away to understand.
Thank you. It'll be greatly, received with the general public. All right.
Thank you.
Okay. Councillor Hill.
Hi.
Turn on your microphone, please.
Sorry. Everything everyone's talked about tonight has been fabulous. But I think if you go down to the grassroots, when we're talking about the GPs, and there's a big problem there. And it's not the actual doctors at the GP surgeries, it's the staff that's within the GP surgeries. And it does put people off. And I'll talk to anybody in my area. You hold on for 48 minutes and it cuts itself off. And that's a long time to be holding on. So it's getting that balance right, and if you can get it right there, then people will be happy to go through the process where they need to get the help they need. Thank you.
Do you want me to come back to that? So I can't answer for primary care, unfortunately, but I have colleagues in the room who probably would be able to provide more.
Yes, so I'll just pick it up very briefly. Yeah, this presentation is about the hospital, but we hear what you're saying. I don't know if James or Beverly wanted to say anything at all from the ISP point of view, but it has been recognised for a while that the Thurrock has less GPs per head of population than the majority of the countries, but it's very much the lower end. I know that the ICB is actively engaged with primary care to try and promote more GPs come to Thurrock. Around, don't quote me on this one, but it's going to get recorded, isn't it? Somewhere around 17 to 19 is kind of the volume we're trying to attract. There are programs in place to try and attract trainee GPs and GPs in their kind of early stages to try and attract them to Thurrock to stay. So it's acknowledged we need to, and we do need to do a piece of work around primary care. We will to this committee bring relatively soon further discussion around the whole neighbourhood health agenda. And I think when we do that around the neighbourhood health agenda, and actually we had a meeting, some of us earlier on today, looking at how we want to take that forward, both the NHS, the local authority, Health Watch, the voluntary community sector. We had the hospice there today, and we had Thurrock Coalition, which looks at supporting co-production, engagement with communities in Thurrock. We will be looking at the real focus that's going to have to be on primary care, primary and community services, because the government shift is very much to move the focus from acute to community, from treatment to prevention, and using technology-enabled care much better. So your comments are heard, they are completely understood. There is some activity in the background to try and encourage GPs now to come to Thurrock, but there is more to be done. Okay, thank you.
Councillor Ellis.
Yeah, just one question really on, you say that we're in a recovery plan and still quite long waiting lists, people still being treated in the corridors. Is obviously it needs to be improved, but is that going to be affected by the £107 million savings target sort of that's needed from the report here? Just wondering if you're still confident that we can still improve the care even with these savings.
No, thank you for that question. So I think my reflections really where we are in terms of healthcare is recognizing that we need to work together as a system, recognizing so what Councillor Hill has talked about primary care, the number of patients who come through the hospital doors, how do we look after them better in the community setting, but also the patients who are admitted in the hospital unwell, when they get better, how do we discharge them from the hospital setting quicker back into the community? Some of the discussions like Rob has shared in terms of neighborhood health, I think that's where we really will see benefits in terms of prevention so that people will live longer, live better in better health, but also if you're unwell and you are in hospital genuinely and you need to be discharged and you need, say, a care home, how do we quickly facilitate that care package, or how do we facilitate for you to go back in your home but with the right care and the right equipment and resources? Because I can tell you as of tonight, I have about 70 patients in the hospital who probably should be in the house, but are still waiting for different bits to be able to facilitate safer discharge. So I think where we would like to arrive at with the intensive recovery program is working together as a system better to improve the flow through our hospital and prevent them looking after our patients in the corridors. There's lots of work we are also doing internally as a hospital to improve our systems and our processes to make sure that we clear corridor care. So it probably is not yet public knowledge, but we applied for some funding. So where our ambulances offload in front of the hospital, we have 3 trolleys, so that's not adequate. So we've been given some money to expand that area so that when we offload our patients, we offload them in a safe environment. We have more space that we can work with to assess them, which means then you can move them a lot quicker. You don't have ambulances waiting, but also the estate, the buildings are very old and they need some refurbishment, so that money will help us to repair the roof of the emergency department. And hopefully with all those interventions, then we should be able to eliminate corridor care. But I think my plea here is that we have to work together as a system to make improvements across the front and the back end of the hospital.
Okay, I actually have a question from Councillor Bennett, who's obviously absent today. No comment on that particular per se. However, she did sort of ask me to ask you, could you please advise where the evidence is that demonstrates that at Basildon Hospital, most patients are being seen and treated within 4 hours, and that fewer patients are waiting longer than 12 hours. So obviously, with no parameters. And she sort of follows that up with a supplementary question. So I don't know which one, if it's fair to let you answer that one first, and then we can go from there.
Yeah, so for Basildon Hospital, so the national target we have for our 4-hour wait is around 72%. We've been performing around 69 to 71%. We'd like that to be better. But again, I think the challenges I've just shared in terms of we have a huge volume of patients that come through our front doors. So on average on a day, Basildon sees about 450 to 500 patients in 24 hours through the doors, which makes it really difficult because the 4-hour wait is contingent on you seeing the patients, if they need investigations, doing the investigations and really turning them around in 4 hours, either to discharge them or admit them in hospital. Which then means, because you have many patients staying in your emergency department, the patients waiting for 12 hours is long, and there are many. And that's why we end up with patients, unfortunately, in the corridor in trying to decongest your emergency department. So, so I think to reassure your colleague is that we are doing that piece of work where you have your ambulance offload, you turn around patients quicker, you then clear your corridors, you discharge your patients so that you have the beds for the ones who need admission, and then hopefully we should start seeing that performance get better. So for Basildon, it's not where it needs to be, but we are doing that piece of work to make improvements.
And now for the supplementary question. She says she would be grateful if you could explain how the evidence is collected, measured, and reported.
I like that question. So we have a system called Shrewd, which is an electronic system, which when patients come in, so when you book them in, they get onto the system, ambulances, and it's a national system, so that data is collected in real time. Of course, we do some validation at times to make sure that it's clean data, but it's very transparent and visible, and NHS England shares the data every week to see where you are, because they're monitoring week on week, so that if actually your performance is deteriorating, then they can ask the question why, what intervention do you need to do? So at least I can reassure her that that data is collected in real time and it's transparent on that system and is shared nationally. So if she wanted it shared, we can share it.
Has anybody got any other questions they'd like to do? Okay. So in terms of the recommendations, committee members are asked to note the contents of this briefing report. Right, thank you. Thank you very much. Okay, we're now on to item 6, which is the NHS Integrated Care Board, pages 37 to 76 of the agenda. Can I please ask Beverly Flowers and James Holden to please present the update?
Thank you very much, Chairman. I know you've got 31 slides, so don't worry, we're not going to bludgeon you with all 31. I think we're just going to speak to a couple of selected ones and then open for questions as quickly as possible. I'm James Holden, I'm the Chief of Staff at NHS Essex. I'm joined by my colleague, Beverly Flowers.
To the microphone swap. Hello everyone, I'm Beverly Flowers. I'm the Executive Director of Neighbourhood Health.
So Dominic, if you could just bounce to slide 7, please. So in terms of what the ICB is, the Integrated Care Board, or NHS Essex, is the primary commissioner of health services here locally in Essex. So we commission about £5.1 billion of public money a year into Essex health services, and as such help set the priorities. The ICB as Essex was only created on the 1st of April this year. Beforehand, we were 3 separate ICBs, one for Mid and South Essex, one for West Essex, which was also linked to Hertfordshire, and one for North East Essex, which was also linked to Suffolk. The decision to merge the 3 was primarily born out of a government savings target. So they wanted us to save about 50% of our management operating costs through a merger, which we have done. The reality is, even though this has been primarily driven by cost savings for the public, it has created a better system for the people of Essex. So having 3 different commissioners across Essex, 2 of which bled into other counties, created a bit of a postcode lottery in the county. So what we commission a district nurse to do in Thurrock is different from what they do in Harwich, is different from what they do in Harlow. It also meant that we were spending public money on separate management structures, and also there was an issue where having 3 social care authorities, so Essex, Thurrock and Southend, there was always a tension of shunting different costs around the system. So having one system in that more united fashion means that we can beat down that level of fragmentation, that postcode lottery nature, and have a more coherent system. The new ICB is different from what the old Mid and South Essex ICB was. So we are primarily now a strategic commissioner, which means 2 things. We will now get involved less in the day-to-day running and operational matters of delivering healthcare and take a more overarching strategic view. By doing that, we can really focus on the things that matter to people across the county, for example, creating more GP appointments, which Beverly will talk about a bit later. And elements of our financial infrastructure have changed. So beforehand, as a ICS, an integrated care system, the whole of the NHS in the county had to balance. As you'll see in the papers, most of our acute hospitals, because of the nature of what they do, are in deficits. Some of the deficits are quite significant. So we had to balance as a system. That included the ICB, therefore having to make additional savings when our hospitals were unable to balance themselves. That's now changed. So in terms of the prevention agenda and the neighbourhood agenda that Beverly's going to talk about, we now have more scope to really lean into that and deliver that care locally for you. So Dominic, if you could bounce to slide 13, I'm going to hand over to my colleague Beverly.
Actually, I think it was slide 11, just to be really awkward. That's what happens when you produce a lot of slides and you decide that you're not going to talk to them all. We thought it was really useful to share, when you come together and you're in your organisation and there's been such a lot going on, it's really difficult when you've got less staff and you've got to become more strategic to actually hone down on the things you're going to do because you want to do them well, because you want to make a difference. And that's been really difficult. So it's been really difficult for us to kind of come together as a new organisation. I have to keep reminding people we're at the end of month 4. So, you know, relatively new, and we've come quite a long way, as you'll see with some of the later conversations, hopefully you saw from some of the slides. So what we've tried to do is narrow our priorities for this year and for the first year of our population health improvement plan, which is the kind of new version of the 10-year plan. The NHS always likes to have a 10-year plan, but it only ever seems to want to deliver years 1 and 2 of it, and then we rename it and then continue to deliver the things we were trying to deliver. So we've tried to focus on the areas that when we took a step back and we looked at Essex's Essex that we thought were really important and that we could make the biggest difference, and supported the learning and the development, some of the really good stuff that was happening in pockets. So I think one of the things we found is that there's lots of good practice out there. We haven't always shared it very well. And we haven't always done a very good job of saying to people what is good. So we've linked it down into the kind of health inequalities and how do we narrow some of those gaps. And one of the things that we're taking to our subcommittee next week is a plan to enhance and extend the care and the support that primary care can put into people with diabetes, to improve the care processes around diabetes and to improve the action plan, because we know in the pockets of Essex where we've put some money into that and it's worked well, it's really improved people's life and their health. And that's also for many of them, because they have more complex needs, had a further impact on kind of CVD and a lot of the respiratory disease. So we want to try and pick that up as something where we've got some really good practice that we can share. We're also really keen, and part of the conversation around developing the neighbourhoods and bringing a post like mine in, is to promote that change from the concentration on hospital care to try and get more care in the community, look at how we deliver some of that support differently, how we identify the real frail people in our community and wrap care around them in a different way. And we've got some really good examples of where practice have started to do that. But also, how do you apply that same principle to families that live really complex lives? How do we link into some of the SEND agenda? How do we support people that have got both mental health and learning disability issues in a different way? We will not be able to crack all of those things in a year. We won't crack all of them in 5 years. But there is something about how do we build on what we've got and start to make inroads and improvements so people get greater confidence that some of the other stuff that can happen. There has to be a focus on those access to elective care, diagnostics and cancer pathways, because they're a national ask. And it links into some of the stuff that, it's really good to hear positive things around the Thurrock CDC. One of the things we're keen to do through neighbourhood health is how do we develop sites like that and really use them? Because where you've got stuff that works really well and people want to go, what can we add in to make it better so that, that care is delivered on one site? What can we do around adding the voluntary sector in? So we've kind of focused those priorities down. We know they won't include everything that everybody wants to see, but we have to kind of start somewhere and hopefully then be able to build on that. I'm going to hand back to James to cover the next slide.
So now if you could go to slide 13, please, Dominic. So we've tried to work out the easiest way to organise ourselves, and as a general theme, we are trying to be an ICB that is pro-local government and has hugged closely to local government as humanly possible. So we think we've got 3 basic levels how we're going to organise ourselves as a NHS entity. The stuff that we want to do once at an Essex-wide level. So these are the types of services that are probably going to involve small amounts of people but are extremely expensive or complex. So things like learning disabilities. So not every single citizen will need to absorb services for the learning disabled community. As a result, the unit price tends to be quite high. So in order to get some of the cost burdens off of local government, we are saying let's have a conversation across the county about how we can deploy some of these big services once as a coherent system across the county. The second level is what you're probably going to hear a lot about in the next couple of years, multi-neighbourhoods. So this is essentially a new contractual framework where we look at where we put the bulk of our commissioning. We've decided that each of our multi-neighbourhood contracts will just perfectly hug the footprint of the new unitary authorities. That way we'll get full synchronicity with the social care system. That's really important for us because we are saying consciously as an NHS, we know we can't fix all these problems ourselves. The NHS is great at adding years to people's lives. We're not good at adding life to people's years, i.e. we're good at keeping people alive for longer, but keeping people well and happy in their community, that's frankly something local government is better at. That's why we're trying to make sure that we align as much of activity as we can with the local government. And then finally, we've got the most local level, which is the single neighbourhood. We've created 38 single neighbourhoods by working with local government colleagues across the county. These are essentially the lowest level of commissioning that we will be aiming to do. We've tried to create communities that are real communities, i.e. places that your mum would say that she lives. So for myself, I live in Stamford-le-Hope. So my single neighbourhood is Stamford, Corringham, Fobbing and Orsett. Because we think people live in towns and villages, they probably don't live in NHS commissioning zone 17. For Thurrock, it's pretty good news because our PCNs, the clusters of GPs, they all represent pretty much what are already natural communities. So we will end up with 4 single neighbourhoods in Thurrock to perfectly match the 4 existing PCNs. So you've got where I am in the east of the borough, then you've got Tilbury and Chadwell in the middle, just above them you've got Grays and Chafford, and then finally Aveley and West Thurrock. So synchronicity with primary care. If you just skip one slide on, please, Dominic. That gives you an illustration of what it all looks like. Now, obviously, we know that there are going to be ongoing debates regarding local government reform and devolution. I would say that a huge amount of the work that we are doing, probably up to 90% of it, can be done regardless of local government reform. So whether or not as an ICB we carry on working with 15 current councils, or whether we end up working with 5 new councils, the things that I was describing, you know, trying to get synchronicity with local government, trying to match our single neighbourhoods with what our primary care colleagues are doing, trying to focus on the things that we want to do Essex-wide to keep everyone's costs down. These are things we can do whether it's 5 councils or 15. So no one needs to worry that we are trying to fetter the LGR process. We're just trying to create as many options and put those options on the table as possible. And then the next natural stage will be looking at that single neighbourhood level, how can we try and match the emerging work that's been done in local government to form neighbourhood delivery committees. So they are the basic local government structure that the government wants to see about how councils will start to deploy services in the future, things like housing and employment support, because that's where I think we're really going to get to in terms of the conversation about adding life to years, not just years to life, because fundamentally if someone ends up in an NHS service because they need mental health support, 2 of the main things that drive people into the mental health service are housing breakdown or economic breakdown. So it doesn't make sense us just saying, well, we'll commission talking therapy and that's our job. No, it makes sense for us to get our single neighbourhoods and neighbourhood delivery committees together, so while the local government is working on housing and employment support, we can try and bring as much of the NHS piece to that puzzle as humanly possible. I will now hand back to Beverly. If you want to bounce to slide 17, please, Dominic.
That's right. So I was just going to talk a little bit about the neighbourhood health model. So I know James rather glibly said we're going for the 15 and we've got the 38 single places. It has taken quite a lot of work to get agreement from within the NHS and within primary care that those 38 areas make sense, not just to the public, but also to the people. So we've done quite a lot of work in the background in terms of how we map our data and how we allow, how practices will be able to identify their population, what the cohort looks like, how that population then uses other services both in and out of Essex. And so to map all of that to enable practices to be able to see it at practice level, and us also to be able to use some of the background data that's provided by the public health team here and elsewhere to be able to look at inequalities and allow us to be able to cut the data so that what each of those 38 neighbourhoods can see relatively around a number of indicators, how they compare to other neighbourhoods, what that looks like and how that helps them to prioritise some of the work they want to do. That's really helpful because that's been quite patchy to date. So when people have thought that they wanted to do work, it's not always been based on evidence, and that's been really difficult for them then sometimes to be able to demonstrate how successful some of the changes have been. So doing quite a bit of that work in the background, we've done it relatively quickly, but it's been really important to kind of get the buy-in and also to help us think about what some of the priorities look like going forward. So I think that's why some of the work we've done probably hasn't been as visible to yourselves and to other partners as perhaps we would have hoped it would have been in this time. So we face a number of challenges in them moving those neighbourhoods forward and becoming mature. In neighbourhood health development within the NHS is seen as a 5 to 10 year journey. And that's because it's about fundamentally changing how people work, changing their relationships and embedding it. It's not just around shifting the money, it's about kind of developing those different ways of working and allowing people to test and make them happen. So there's some really good examples of practices that have brought in, when you talked about primary care access earlier, that have brought in a wider range of staff to support the delivery of their services. So increasing pharmacists within the team, looking at care navigators, so actually employing some people to help patients and the public navigate some of the difficulties of the NHS system. That's happened in a really patchy way, and one of the things that we're hoping to do in the next few months is bring that together so that where that has really worked, we can get people to motor on extending it. We've got a real fragmented provider landscape in Essex. So when we're looking at what does that multi-neighbourhood leadership look like, we haven't yet identified which provider will lead each of those areas, and we're working with all of our partners across the NHS to say what will that look like. So we've been doing some work in particular with primary care to help them think about how they become a more equal player, how they have a kind of more of a voice, and to support them in understanding what other services they can take on. That is not going to be quick. That's going to take a good few years to make happen. But we do have some examples of some PCNs already that are pushing forward to provide a much wider range of services and are happy to help their colleagues catch up. So I think we've got over a little bit of the competition of we can't share, or if we share, patients may re-register. And actually that's really positive. Can we move on to slide 23? Oh, no, back one, sorry. I must have my numbers wrong. We talked a little bit around the kind of model, but in the pack there's a big national programme to develop neighbourhood health centres. And we had to submit a plan for the whole of Essex to say, if we really wanted this to be successful and we wanted to move stuff out of acute hospitals, and we wanted to make the best use of the facilities we already have within our patches, what would our priorities be? How would we want them to work? And they fall into 3 levels. So core, core plus, and core plus plus is just about the range of services they have on the site and the scale of the population that they could cover. We submitted it in about 6 weeks ago. And today we heard they want to explore with us further our model and moving forward a number of the sites. What we're trying to do, and one of the reasons that we kind of highlighted the sites in the way we did, we highlighted Thurrock Community Hospital as one of them, is that bit around where we already have some investment and we have some new services go in, we need to maximise the use of those buildings, not keep investing in new buildings that we only half use. And we also recognise that with some of the stuff around local government review, it is possible that there'll be other buildings that come up in some areas where we could do drop-in stuff and we could do health on the high street in a different way. We're testing some of the health on the high street models at the moment. We've got some work started in Harlow where we've actually put a wide range of services into the shopping centre to see how that works and to see how it goes. It works really well in some parts of the country, but a bit like when they talked earlier about screening and vaccinations, it doesn't work well everywhere, and we don't really understand why not. So we're going to test that out in Harlow, see what that looks like. I think there are some real opportunities to look at how we consolidate services, and we've used our approach to, if you go to the next slide, the map. We used the map and we mapped lots of data around our population, around need, to say, do we have a good coverage of these sites and what does it mean? And we're now doing something that's really complicated, but I hope we can share with you later in the year, which is we're now looking at primary care estate and primary care practices and saying, where is it, if you use the same model and the same approach around need and space, how do we prioritise where we need to put money into developing new practices or extending existing practices, or what are the opportunities for making better use of some of the estate that we've got associated with practices where those buildings are not fully utilised. It's the first time there's been an attempt to do that as an Essex basis. It's been done in a really piecemeal way previously. I think what that'll help us to do is move forward some of those discussions around primary care practices and premises and changes more quickly. It also helps us to think about how we direct some of the capital that we have available to us, but also the work we need to do with NHS England around additional capital. And we're hoping it'll link into some of the work that James is doing to help us align better with some of the 106 requests, where we've not always been as good as probably we should have been in the past, around sometimes lining things up and at other times saying when things either weren't going to work or they were, or when the NHS timeline is different to the planning timeline. So we want to try and use something that's much more evidence-based to kind of look at those premises and also to move forward the schemes that we know we need to move forward. That won't solve everybody's problem, but I'm really hoping that it'll help us to make quite significant progress. I think I'm handing back to you.
Thank you. If you can bounce to slide 26, please, Dominic. Don't worry, we are getting to the tail end now. So what Beverly was describing in terms of essentially wanting to get services out of hospital and closer to where people live, to do that is predicated on having decent buildings to put those services in. One of the things that historically the NHS just hasn't done well enough at is working with local government at building new infrastructure and building it as quickly as it needs to. So as a part of the planning process, when a developer comes along and builds 10,000 houses, they say, well, as a result of these 10,000 houses, the population will increase by X amount of people, therefore we will give you a contribution. Those contributions can be problematic for the NHS in three ways. Firstly, the contribution can at times be in areas where, as Beverly was outlining, it's not actually the strategic requirement. Sometimes the pots of 106 money, the development contributions, can be a series of tiny pots that frankly are just too small or disparate to be used. You know, I'm not entirely convinced if we have a 106 pot of £45,000 in one area, how far £46,000 in the village of Aveley would actually go. And then finally, it creates a problem because sometimes the 106 contribution isn't cash in nature. Sometimes a developer offers us to create a facility that we will then rent. The problem is when that is done, there are rules regarding what we are allowed to pay in rent, linked to the district valuer rates. Sometimes a developer will create a facility as a part of a development and then offer it to the NHS as their health contribution, but the rent will be, frankly, so far in excess of what we're allowed to pay. We are sometimes accused of choosing not to use a facility, but actually the facility that has been offered was offered in such a way that the NHS couldn't use it. Now, these three problems largely erupt because of just the nature of our planning system. So it's not something specific to Thurrock, it is a national problem. The NHS, when developments take place, we get asked strictly, based on a set formula, what does the area need? So I think it's something in the realms of for every 1,750 patients, it's about 120 square metres that's required. So we offer that, and then that is the extent of our involvement. That then filters through to the rest of the planning system. So one of the conversations that we want to start to have with local government from September onwards is what is our role, what could our role be, working closer with local government and actually being a part of that mitigation phase when 106 agreements are being shaped through the planning committee. So we could perhaps turn around and say, rather than a developer offering us a piece of land, instead someone from Beverly's team can come forward and say, actually, I've looked at Thurrock, what the people of Thurrock really need is X in the following area. So rather than offering us a piece of land, which invariably takes several years to build out, and by then inflation has kind of made it too expensive to be viable, instead it can filter through to a more strategic requirement, and we can actually get into the process of delivering for local people a lot quicker. We know this is something we need to get better at. As we've become one ICB, as I said, we had to find 50% management savings, so we lost about 40% of our workforce. One of the only parts of our ICB that's expanded is our estates team, because this is how seriously we take this challenge, and doing this work with local government is one of the main jobs that I do as the Chief of Staff. I'm now going to hand back to Beverly.
Oh, if we go to slide 29. So I think the whole issue around access and data and performance is probably a topic for another meeting, because I think you could probably do a couple of hours on it. But we thought it would be remiss of us to come and not include a couple of things. And it was interesting that you were talking about the primary care and the triage and the telephone lines. I'd be really interested if the people involved are happy for you to share with me the details of the practice, because one of the things we protected in the changes is our primary care access team. So we've maintained a team that's only job is to try and improve primary care access and primary care practice delivery. We're trying to do that work much more closely now with GPs. So we're trying to work with GPEC as the kind of overarching GP body to say, we know a lot of this works better when peer pressure is applied. So can we work with you to bring some GPs into the discussion about what works well and what doesn't? When you take a step back and we've started to get data across Essex, we are beginning to make inroads. So we are seeing more appointments and we're seeing a rise in satisfaction. It's interesting because we're still seeing lots of problems. So you don't solve everything, but we are beginning to move in the right direction. One of the things around doing a lot of the online triage and the online booking is to hopefully mean that the telephone lines are not so busy. And we now have a number of bits of technology that we can install for practices around how the ring back works, how people ring back and how you can leave your details and they contact you back within an hour. So I was really interested that there's still a practice that cuts you off after 40 minutes. I know of a couple, I didn't know there was one in Thurrock. So if you let me know which one it is, we will genuinely, I'll follow it up because they are things that there are solutions that really help. And I think it really helps the staff in the practice as well as the public. And I think people don't always realise it. So happy to pick that one up. If we just pop to slide 32, because I just wanted to pick up dentistry. So MSC invested a lot of money as an ICB in improving access to dentistry, and we have one of the best access rates to dentistry in the country. We're rolling that out across the whole of Essex. We've also been rolling out some of the work around orthodontics, and we've agreed an uplift and an increase in activity for NHS dentists and NHS orthodontists for this year, because we want to keep building on that. We're beginning to see we're beginning to see a greater growth in people accessing NHS dentistry, but one of the things we're really keen to do is keep promoting to people that we have a lot of NHS dentists. They're out there, most of them still have open lists. It may not be your dentist of choice, but you should be able to find one. We've also run a pilot that we're extending around dentistry in care homes. So we've got a group of dentists now that go in to support our care home residents and do training with care homes. And that's having a massive impact. And it's having a massive impact on people's ability to eat and their kind of nutrition. And it's having a range of unforeseen benefits. Our intention is to roll that out and to evaluate it and to sing about it a bit more, because there aren't many of those schemes within the country. But I suppose the dentistry bit is we're just really keen to keep getting the message out there that it may not be perfect, but access. We've invested quite a lot of money. If people find areas and pockets where there are still problems, we're always keen to hear, because we can usually, through the networks we've got now, look at if there are options to bring other dentists on board. So I just wanted to cover those two bits of access, recognising that it's probably not going into the level of detail you would want. Am I handing over to you to conclude?
Yep, slide 36, please. And this is the last one before we open up for questions. So one of the other areas that we know we've got to improve is how we deal with community groups, charitable groups and the faith sector. So we haven't got this relationship right. When I became Chief of Staff in September of last year, we had in Mid and South Essex well over 1,000 contracts with community groups, which is just impossible to monitor that many contracts. But we've also created some real problems in the community market. So we've given out a lot of contracts that are only a year long. As most people will appreciate, by the time you stand up a service, you're 2, 3, 4 months in. Therefore, you don't get a full year of service. So, of course, by the end of the year, by and large, you're failing the evaluation because we've only given you a year. We're also, because our contracts are so specific and, frankly, overly so, we're forcing a lot of community groups to compete with each other for our money. Some of our contracts are so specific, it actually dictates what you do per day, which is a problem. So what we are looking at now is to create what we're calling convener models. They will be on the footprint of each unitary authority. That will be how we devolve money directly out of the NHS into bodies that are led by the community sector. We will only set them high-level mission statements. So the list of priorities that Beverly showed you earlier, our Health Population Improvement Plan, our PHIP, Population Health Improvement Plan, PHIP, we will say to the conveners, we are very concerned about, for example, unvaccinated mums. And rather than tell them, this is what we want you to do and how we want you to do it, they will simply have devolved money and devolved competency to work with the community. So, for example, Councillor Hill, I think it was Councillor Hill, referenced the Health Open Day that the Stanford PCN ran at the Hassengate surgery at the weekend. I wandered up to it, and it was really interesting because you had a GP surgery about 20 foot away where lots of people hadn't been going for their vaccinations for a whole range of reasons, and yet if you're serving hot dogs and there are games for the children and there's all sorts of other things, people were happy to wander on the vaccination bus and say, oh, out of curiosity, what vaccine should I have had that I haven't had? So we think that's probably a more productive way of deploying our money, but it's also a way that we can start to repair some of the damage that's been done to the community provider market. So that's a brief canter through, Chair. Thanks for your forbearance, and we're both happy to open for questions.
Councillor Stringer.
Just one point. We've got a really good doctor's surgery. Fantastic. You used to be able to go in there at 9 o'clock in the morning. You'd have an appointment same day by 9:15, 9:45, something like that. No problems there at all. They've gone over to e-consult now, which is really a real big step backwards in my mind. Like, it's, you know, you're looking at sort of a couple of days for it to come back. But the main problem is, as I say, fantastic service at the doctor. Like a couple of years ago, I'd done a shoulder injury, went to my surgery, had a scan on it at Purfleet the next day, referred me to physio, waited 9 months for an appointment. When I got there, all they done was give me a sheet of exercises, said you'll hear in a month's time of a follow-up. I had a follow-up 8 months afterwards with another sheet of exercises, and they said they'd follow up, and I still haven't had that 9 months on. Ended up paying 200-300 quid privately for a sports massage guy, and the exercises they gave me basically weren't any good for what the injury was anyway. Like, but that's the thing. Like, you get really good service at the doctors, and then when they refer you, it just lets the whole system down. And I don't know if there's any way you can see how that sort of improves, you know.
I think it's a really good point, and it's one of those things about there's lots of handoffs at the moment and there's lots of referrals on, and you're right, some places have really long waits. So one of the reasons that we'd quite like to have the single neighbourhood contracts, and we'd like to think about what we can do more locally, is if you've got a neighbourhood health centre where your CDC is at Thurrock Community Hospital, and you put physios in there and you put services in there that link into you as a community and not a provider or Essex, does that then help you to be able to streamline some of those pathways and do some of that work? And it might not solve everything overnight, because we do have long waits for a number of things, but it might improve and reduce some of that duplication. So one of the other advantages of CDCs with a bit of space around them is, can you also make that into a same day appointment? So could you go, and we're putting a pilot in at the moment actually for gynecology to say, so could you go and have your outpatient appointment, your tests done on the day, an hour and a half later, you could have a conversation with somebody about what it looked like and what the next steps were. So how do we get some more of the one-stop shops in? And how do we get where we know some of the things become advice? So some of the physio, some of the OT stuff, you see somebody that's advice. How do we do that a bit differently so you're not on a waiting list when you kind of know what the outcome is? We won't be able to do all of that really quickly, but it's one of the things that we need to keep building on, because it works well in some places but not others, and we won't be able to do it for everything at once. But that's one of the reasons for wanting to do some of that neighbourhood health stuff and wanting to put some of the money through GPs, so to give them the budget so that they don't provide the services but they have a greater say in who they use and how they commission it. If any of you are old enough to remember fund holding, it's like a really big version of that. So there used to be a thing called GP fund holding. So GPs in the dark and distant past did something very similar to what we're trying to promote in neighbourhoods, but it was voluntary. It wasn't part of national policy, it was a set of voluntary schemes. So in some parts of the country, there were lots of people that were really entrepreneurial and there was a lot of it. In other parts of the country, it just didn't take off. So this is about trying to embed it better.
Councillor Shennick.
Yeah, following on to what your question was, I got referred to the physio at Thurrock Hospital, who didn't treat me or anything, he just gave me a piece of paper. But I think the government have missed a trick here, because when you go to a private physio, they actually work on your, you know, what's wrong on your shoulder or your back and so forth. So why are we paying these people to be physios, but they're not physios because they're just giving out bits of paper? You could go to a nurse and she'd give you a bit of paper, you know, and I think it's atrocious that they ever call them physios, you know.
Oh, I'm not a physio, so I can't answer the detail of the training. But I think there is something about what is it we do to help people understand when advice and guidance is the bit that you will get. And that probably means you don't need to see the professional. So you didn't need to see the physio. How does that assessment happen in a different way? And how do we get much better and clearer about where people do need treatment and what that looks like? And a bit blood test and physio is probably two of the things outside of primary care GP appointments that when you talk to people that you hear about the most in terms of pathways not working, frustrations, not really understanding where they are and why. And you're right, we have to make it better. I think understanding how we do that might be a slightly more challenging than we all hope.
Yeah, I mean, going back on that, I think that if they did treat you as a private physio, I go to, I'm fortunate enough I can afford it, I go to a physio once a month for my back, keeps me up and moving. But if the actual physios did their work in the NHS, it would probably relieve a lot of pain management and lots of things, you know. And this is things we've got to look into.
Councillor Stringer.
Yeah, can I just follow up on that? The guy who's done my back, long story, 5 years ago I done my ribs, and when he come to do my shoulder, I laid on his couch, he ran his hands down my back and he said, you've had a rib injury, that's what's caused your shoulder injury, which you didn't get there. Now he's actually doing his masters in physio, and he has to go to hospital now for a year as a physio, and he's not allowed to touch people. He has to give them an exercise sheet, and that exercise sheet, he said, is the bare minimum that they can give someone that they don't injure themselves, because if they injured themselves, they'd sue the hospitals, and that's what he's telling me that he's being told at the physio at the hospital for his masters.
I genuinely don't know. It's not something I can comment on. We can certainly say we have responsibility for the training hub, but the training hub only really picks up primary care training. But I can certainly go back and ask a couple of questions.
Okay, Beverly, I'm going to jump ahead a year now. So come back here this time next year, and you're going to say, oh, we've got all of our successes. What successes have you had? Bearing in mind that we're on a journey of 8 to 10 years.
In 4 months.
Well, this...
No, so this time next year, I think we should be in a position where we have identified and we are providing better care to the 1% frailest population registered with primary care, many of which are elderly, but not all are elderly, and that they will have better wraparound care and proactive care in the community, because we're quite a long way down that pathway now. It is not consistent. I think we will have better compliance and better engagement, and therefore better outcomes around the care processes and planning associated with people that have diabetes and their ongoing care. I think we will have begun that wider shift of the commissioning of a number of services to be more owned by primary care. I'm very hopeful we will have improved primary care access and continued that journey. I think we will have done a number of other things around how we work with the acute and community providers to help them develop into the new world and support the new ways of working, because we shouldn't forget how difficult that is. And I don't concentrate on a lot of the acute stuff. So if my colleague Sam was here, she'd be talking about waiting list reductions and a whole range of those things, which are equally important to us as an organisation, but aren't in my sphere of work. I think one of the things that I would like us to make progress on, and I'm probably less clear that we will, is some of the inequalities work we need to do, because taking a step back and looking at some of the inequalities across Essex has been more challenging than we thought it would. So getting the data, being able to look at it, understanding what it means, but also beginning to understand where, as James said, some of it isn't for us to intervene. What we need to do is support others to intervene, and support them sometimes with money, but quite often support them with information and access. So I think they'd be some of the things that would be better. They won't be perfect, but they will be better. I also think, in terms of the Better Care Fund, for somewhere like Thurrock, we've got a really good understanding of how we spend that money, and we've got a really good understanding of what it does. We haven't always shared back very well jointly the real benefits that that's had to the population. And I think that's something we can do relatively quickly that then helps us to build on the next stage of how we use the Better Care Fund going forward and how that supports that wider change. I think there's a load of really good work. We just don't talk about it.
And just to build on Beverly's comment, Chair, there is a huge amount of good work that we don't talk about. And one of the reasons that we want to form that better relationship with you is to help advocate for the areas where, a bit like Beverly gave the example of dental care, where we are making improvements, but we need to bring the public along with us. So just for an example, the talking therapy service that we are currently going through a procurement exercise for, that's kind of like the bread and butter mental health support. For Thurrock alone, we're currently delivering 2,113 appointments per year. By the time our new contract is at full flight, we should be delivering 2,556. That's an extra well over 400 people a year, or 400 appointments a year, serving people here. That's a piece of information that was so niche, it only came to me, Chair, when you asked your question, because it wasn't in the slide pack that I put together. So by having more sessions like this, deepening our relationship, hopefully we'll be able to tease out those areas where actually we're making quite a lot of progress as a healthcare system, but perhaps residents aren't always able to be the beneficiaries of it at times because we get buried in an awful lot of other stuff.
Thank you for that. Councillor McCabe.
Yeah, it's all right. I just want to congratulate you on your mention of the 106 monies. Hooray! Thank you.
That's the first time I've ever heard 106 get a hooray at a committee. Yeah. That's a new experience. Thank you.
Kim, please.
Thank you. It was really just to add to some of the things that Beverly and James have both said. So, Health Watch has sort of been in place for quite some time. Well, I've been knocking around for about 17 years now. And we do listen to the residents' voices around their lived experience of using the services in Thurrock. And we work quite closely with the access team. So when we get patients telling us that they're having difficulty to getting appointments, or they feel they're being blocked, or they can't use the system that's in place, we very much know what GPs should be doing and what they should be offering. So we'll always go back to a GP practice and say, sort of talk to them about why these patients are having this problem. And if we don't get anywhere by having that conversation, we take it straight to the access team, and then they come out and they'll have a look at it for us. So just use us for that. Plus also, we've been talking to James and the team around the Health Watch contract. So the 3 Health Watches will work together that cover Essex to make sure that the ICB are not ticking their own or marking their own homework, so that we are independent enough to be able to challenge and say this isn't working or this is not a good idea. But we only do that. It's not my view or our view, it is what we pick up from the residents of Thurrock. So we are there to provide a service, and if you guys need us, then I'll make sure that Claire sends all of our contact details out to you. As I say, we are independent, but we will look at what's not working for Thurrock residents.
Thank you. Councillor Heal?
Just a couple questions. You're going to roll all of this out, and I find that talking to residents and I find it from personally, you ring up a doctor, oh no, we don't do it like that anymore. Well, when did you stop doing that? And those people that don't actually go to a GP or a doctor for quite a while, we're not advised. So feels like you've got a lot of changes going on. So how are individuals going to be told about this? And secondly, sounds like there's a lot of work being farmed out to other levels, because you find that it could be better to do all that in one stop. Are you kind of employing more staff to account for this? Or are these people just going to be overworked? Sorry.
So, we're not employing more staff. We've had a 50% cut in staff. But one of the things that we are supposed to do is become more strategic. And actually, one of the things that we run some PC. So in the north of Essex, we have 3 PCM pilots that are part of a national programme. And they were each given a small sum of money to change their services, enhance things and do things differently. But they weren't to spend it on management costs. They could have a small element of it, but it was about changing how they behaved. And 2 of those 3 have demonstrated really well that they've used a small amount of money, they fundamentally changed how some of their services run, and they've increased the number of people that they see and treat. We put no management overheads into that, but what we gave them was a little bit of flexibility, and they employed like a half-time person to support the coordination. So there's something about how we as an NHS get better at realising you don't sometimes need lots of people to do the implementation. You need to give people the freedom to do their jobs. And that's good, and that's a real struggle, and that is a real struggle. And I think the other point you raised, which is a really good one, is we have to get our compact and our relationship with the public better and different. Changes only work if both sides of the change agree to them. And I say this a lot. One of the reasons that online consultations have such a bad press, and they work really badly when they first came in particular, was we did a really good story of telling why it was great for the consultants, it was great for the doctors, it was great for the NHS, and it saved everybody this time. We didn't talk about what it meant to the patients. We didn't talk to patients about what it meant to those of them that use that online service, or what it was meant to mean for those that didn't in terms of how it freed other things up. So we kind of created our own problem because we didn't talk about what we were going to do in the right way. And so we've got a real challenge as an organisation to talk about some of the stuff we want to do in a different way. And one of the things that's coming around diabetes for sign-off at the committee is we've put some money in there for practices to do training and development, but including with their patient groups and with others to say, so if you're going to implement this, what would you like and what would work? Not, you have to do it like this. As a way of testing whether that will make a difference. So I know that doesn't fully answer your question, but it goes somewhere to say, and you're right, and I think, one of the reasons for coming to things like this is it allows you to hold us to account for when we do get it wrong, but that's also why, Health Watch and other organisations, we have to get better at having some of those conversations in a different way, because NHS is a two-way thing, isn't it? It's about the people, that are you'd be customers, in other words, and, customers should be treated with respect and have a view about how their services are delivered.
Okay, this is the final question. Mr. Stringer. Oh, sorry, Councillor Stringer, I beg your pardon.
I said I wasn't going to ask any questions, didn't I? On the Section 106 money, so suppose we had a company wanted to build 1,000 houses, and you say for a doctor's surgery we need so many square feet per number of houses, etc., etc. So suppose we got a doctor's surgery built that matched the requirements that you needed, the square footage and everything like that. Would you have the doctors to service it?
So one of the frequent problems that we have in primary care, and Beverly, correct me if I'm wrong, is quite often there are additional clinical services that could be run, but there's just physically not the space to run it from. So there is, there's not infinite money in the GP contract, but there is a fair amount of flexibility to add services to respond to a community need. quite often what we have is, especially in Thurrock, where we still have quite a few practices that are in the old-fashioned model of in a terraced house somewhere. You know, physically, if the population of, you know, I would take Malvern expands, and the main GP is in a terraced house, well, the terraced house isn't going to expand, even if the village is expanding. So that's where we need to get better and quicker at working with you at creating that space. But I'm sure Beverly can say something about the contract itself.
Well, I was going to say something about the workforce, because I think one of the things you're saying, are there GPs out there? So if you'd asked that question 3 years ago, I would have said it's really hard, because there are far more vacancies than there are qualified GPs. We're in a position now where there are the kind of balance of vacancies and GPs is much closer. So there are a lot more GPs out there, both newly qualified and continuing to work, looking for work. We've been doing some work. We host the training hub, which is responsible for kind of training and trying to recruit GPs. And we've been doing a number of things. We've been doing something to help understand what it is we need to do to make any part of Essex, including Thurrock, an attractive place to work. So how do we stop being our own worst enemies by telling everybody how terrible it is? And actually tell them how good the area is, the mix of the population, what you do, what it's like. So we had become really good at encouraging GPs to not become GPs because we told them it was terrible. So there's something about how we do that. There's also something about we've done quite a lot of work, and we're doing quite a lot of work with existing GPs that want to work part-time and hold portfolio careers. So to help people have that kind of flexible way of working, and to keep some more of our more experienced GPs from fully retiring. So whereas there weren't a number of people, for most roles we put out now, you have more than one application. So whereas at times we had practices putting out for posts and nobody was responding, for most roles now there are enough people for them to have a panel and interview. And inner city and complex, kind of like city and complex urban area practices are growing in popularity because they allow people to work part-time. They often allow them to have a special interest, so they allow them to be able to develop their other skills. As you might have seen if you looked at the press today, there's a real issue with a lot of the real rural communities in the smaller rural practices, where it's really difficult, where you don't have the numbers to kind of support a real multidisciplinary workforce. So we should be pleased we're not in Yorkshire. I was reading that article today.
And I would also say we've got to get better at also promoting all of the clinical routes that are not GP predicated. So there's a fantastic scheme that's running across the country called Pharmacy First. There are 7 core conditions that pharmacists can deal with now. You do not have to go and see a GP first. And if anyone's interested, Wales for years have had a huge amount of their pharmacists as what's called independent prescribers. So you do not need to go to a GP, get a prescription and then go to a pharmacist to fill it. There are lots of conditions that pharmacists can prescribe and dispense for you themselves. One of the problems with Pharmacy First is when the government put all the money into the pot, I think it was initially £600 million, it just wasn't getting spent. It wasn't getting spent either in quantum or in speed. So there is a huge reserve of strength in community pharmacy here in Thurrock, and it's actually surprising how many conditions that pharmacy can treat that people don't naturally assume that they can. So that's one of the things that, kind of go back to Councillor Hill's comment about communication, we need to get better at helping work with our colleagues to remind people that, yeah, we are creating more GP appointments in Essex, but actually you may not always need to see a GP. It may be actually faster and more convenient for you to wander up to your pharmacy and say, I have this, can I be treated?
Thank you very much. Yeah, fortunately, I think I've got an improvement. I've got to sort out my time management. So, yeah, we're going to have to move along. So thank you very much. That was very edifying. I got a lot out of that. Thank you very much. Okay. So with that, I need to, I've got to say that last bit. Yeah, so, this one. It's the wrong one. I've lost my train of thought. All right, okay. So recommendations of this, the committee are asked to take note and update of works undertaken and the next steps. Okay, we're now moving on to item 7, the work programme on pages 77 to 80 of the agenda. Claire, can you please take us through the work programme?
Thank you, Chair. I will take items 7, 8 and 9 on block just for ease and timing. So in relation to the work programme, since the publication of the papers, it has been agreed that the health and wellbeing strategy will be moved from the September meeting to our November meeting. And I'm also working with colleagues in relation to the complex housing intervention project being added to the work programme as part of a pre-decision scrutiny before it progresses to Cabinet later on in the year. I'll pause there for a second in case there are any questions, and then if not, I will move on to the action log. No questions on the work programme? Perfect. What I will do then is move to the action log. So you'll see that in the action log there was included actions 1 and 4 from the previous municipal year. I've discussed these with the Chair and the Cabinet member, and we've agreed for these to remain open. In relation to action 4, the committee can also consider if you wish to receive the items as briefing notes. And actually, James mentioned about the talking therapies procurement, if that would potentially be of interest to the committee, so we can take those forward. Have anybody got any questions on the action log at the moment? No? Okie dokie. I will move on to the recommendations tracker. So you see this is quite a blank document at the moment, but it complements both the minutes and the action log to highlight the scrutiny journey of reports with discussions and recommendations summarised. So we'll also include briefing notes that are circulated to the committee outside of the formal meetings. So that's included as part of transparency and access to information. And also included within that same document is the items that sit within the committee's remit on the Cabinet Forward Plan. So it's part of strengthening the relationship between the executive and the scrutiny function as part of that critical friend model. And I'll leave it at that, Chair. Thank you.
Thank you very much, Claire. Okay, so that just leaves us to close. So thank you, everybody. And that concludes the business of this meeting this evening. And now declare the meeting closed at 9:21.